computer's unbelievably slow. It was more efficient last week, everyone. I do apologise for those of you who've joined. This isn't usually the level of disorganisation and chaos that I try and provide you with. Right, back again. So lightning strike. So I'm sure you can all see my slides now, or my whole screen, hopefully. And we're just recording that centre box. So that's what that's the reason why it's laid out the way it is. So lightning strike. So 4 main types of way of getting injury. So direct thunderbolt strike, side splash, which is more common, where the current jumps off from a nearby object. You've then got ground current, which is where the ground is struck and the current travels through and makes contact with the body that way. And then contact injury, which is uncommon, but it's where another person is struck and if you have contact with them. And then in terms of how it actually causes injury to the body, so it's predominantly through the electrical current going through the body tissue. And then, as well as that, it's partly due to conversion of that electrical energy into thermal energy, and these are the 2 mechanisms by which damage is caused. And then finally, indirectly, mechanical trauma. So actually being thrown physically by the action of a bolt onto rough terrain and injuring yourself traumatically, or being hit by debris as a result of a strike elsewhere. So these are the kind of the main ways in which it causes injury. And just because everyone likes a nice pretty picture, we get these sort of very particular and very specific ferning patterns that can be seen on the skin of these types of burn marks, and this is very specific for lightning injury. Now, in terms of the type of way that this can cause death, very commonly, as with a lot of trauma, death may well occur immediately. So before there's any chance for rescue services to actually provide any form of worthwhile input, and this will either be through a cardiac arrest, so putting the heart into an electrical rhythm that means that it can't circulate blood around the body, or it may be that it suddenly impairs the body's ability to breathe, and so these patients will often be dead on arrival of medical services, and I suspect there's relatively little that can be done for them by us. But if the casualty is alive by the time we get to them, the range of injuries that can be caused are unbelievably extensive. I mean, I know I've got relatively little personal management of lightning casualties. So in my reading of it before this, I mean, essentially every single body system can be affected to a variety of ways. So the neurological system, so the brains, the spinal cord, and all the nerves leading to your arms and legs can be significantly damaged. Skin burns of a variety of severity. But this sort of high thermal and electrical current can cause all kinds of other things. So it can cause your eardrums to rupture, and cause your lungs to rupture, causing a pneumothorax, which we'd normally see through a traumatic type injury. So really, these casualties are potentially a complete mess if they're alive by the time we get to them, with a whole range of issues. So, in terms of what we do, though, not really anything different. So I've written down this sort of ABCD type structure, but I'm sure you'll realise that there isn't really anything different to what you've been taught. So essentially, in terms of our doctor's ABC, and this is the kind of stuff that comes out they try and eke these things out in your theory exam. So they don't particularly want you charging across in the middle of an active thunderstorm, with an ice axe on the back of your rucksack, or a lecky with poles waving in the air to go and do a primary survey of someone who's been struck by lightning. And this is the type of thing that they try and emphasise in the exam. So it's all about self-preservation. So in terms of what I put here, so the closer the event to the lightning strike, the more likely you are to get struck. Once the strike has occurred, there's no risk of the charge discharging to you. So you can touch and you can assess a casualty without being at risk of receiving any injury from any active current. There may be residual heat on metalwork. So, and that's also important. Going back to this slide, I've sort of miscellaneously chucked in this bullet point of remove jewellery. So anything metal on the system can obviously be hot and can cause ongoing burns. So D may be dangerous to self. Response. The casualty can basically be anywhere on the spectrum from unconscious to completely alert, depending on the severity or the amount of injury caused by the lightning strike, which again will depend on the amount of voltage that was transferred to them. S, shout for help, obviously, and then check airway. Consider chest wall injury for B, exactly the way you would if it was a patient you were assessing for trauma. C, I put sort of by now you will establish whether or not they're in cardiac arrest, because if they're completely unresponsive and not moving or making any sign of life, you're going to start your BLS type sequence when you first assess them. But just be mindful that the heart muscle and electrics can remain irritable for a period of time afterwards. So regular reassessing their C category is really important. D, so they might have any form of neurological abnormality. So they might have any form of symptom of almost like a stroke type pattern. So they might have impaired power of the limbs, abnormal sensation, speech abnormalities, reduced conscious level. They might have difficulty seeing or difficulty hearing because of direct damage from the lightning strike on these organs as well. And then they're also going to be very high risk of having burns. It's important that the extent of the burns is investigated, because it's going to make their end destination very important. It's going to have to be, these patients are going to go to a major trauma centre, but they're going to have to get burns input as well relatively swiftly. And in terms of helping to again sort of prognosticate and work out where these patients are going and how quickly, having a good idea of the extent of burns over the body is important to get documented. And on the discussion last week, we talked about burns and how to map out and assess burns by using this principle of nines, and that's all in the lecture that we talked about. And finally, E, so you're going to expose a casualty in an environment where a thunderstorm has recently taken place. So it's likely going to be cold and it's likely going to be wet, so you need to take care of them. That's about it, really. I'm not sure there's a great deal more. I'm certainly not an expert in lightning strikes, but I think the main principles to be taken away for your exam is a strong emphasis on looking after yourself under that D category, and then after that, basically cracking on with your primary survey in the same way that you would do otherwise. I don't think there's any specific deviations that we need to start making. Does anybody have any questions on that, or any thoughts, or anything they want to add to what I've said? No? Okay, fine. In which case we shall move on. So part of the syllabus talks about sort of all the other unwanted things that we get from being in the great outdoors, and this may happen on people who are out in the hills, or it might be if you're acting as medical cover for like a lowland summer fete, which I know that quite a few teams do, and so your everyday summer bites and stings have the ability to be an annoyance to potentially being a life-threatening injury. So what do we talk about? We're basically talking about any insect that can bite and can cause injury. So obviously wasps and bees and hornets and horseflies are all on this spectrum of insects that bite and can cause harm. General principles. So if you've obviously got a big barb stuck in your skin, try and remove it as superficially as possible without trying to disturb it, but try and remove that. The vast majority of people who will have a reaction, it will just simply be a local reaction. I mean, you all will have had bites and stings in the past, and I'm sure that most of you will have had a very simple reaction to it. So some pain, swelling, redness around the site, maybe a bit of itchiness around the site, and that's pretty much it. But the problem is that a small number of people, often most of which will already know that they have an allergy, but not always, may well progress to a far more serious reaction. And that sort of response to the body to a bite or a sting progresses all the way from a little bit of local redness and swelling, which is the body's attempt to try and fight off this sort of unpleasant thing that's been injected into them, all the way to a massively inappropriate response to the body where it goes into an anaphylactic reaction and it sets off this cascade of events that can be life-threatening. And certainly the increased amount of exposure to that bite or sting increases the chance of that potentially happening. So if you have someone who's had multiple stings, they disturbed a bee's nest and they've been stung 15, 20 times, that the amount of what we call the antigen, which is the thing that is upsetting them is going to be higher, and it's going to potentially provoke a stronger reaction. So we will talk about anaphylaxis later on, hopefully tonight if we get around to it. But I'm sure that from your Cascare you'll know that your anaphylaxis typical reaction is very severe. So you're talking about swelling around the lips and the mouth, having difficulty in breathing, problems with blood pressure, so they often have to lie them down, and then a whole load of other reactions. This is the body just not liking what's happening, so diarrhea, vomiting, and then usually quite an extensive rash over the body. And these are the signs that this is potentially a bit of a warning sign that something bad's happening. Certainly, if there's swelling around the mouth, that's a really worrying sign, because that makes us worry about a loss of an airway. Now, it's often quite helpful that a lot of people who are allergic to simple bites and stings will often know, not always, but they'll often know, usually because they've been exposed to it as a child. And if in that case they'll be able to tell you, and hopefully they'll carry an EpiPen or some kind of adrenaline auto-injector with them, so that they're pretty well versed in what to do, and often they may well guide you with how they're best treated, because they've been in this situation before, they know how their body responds, and often instead of us leading them into their care, we can take some lead from them, and because they'll know how their body's likely to respond. But like I said, often it may well be the case that patients haven't had a particular bite before, or developed a new allergy out of nowhere, which is possible. And so we've got to be mindful that this can happen. I'm certainly not wanting to profess any particular strong knowledge about the about the fauna of our country, and I'm sure that some of you who work in the outdoors will have a lot more detailed information about the various snakes and other funky creatures that we've got. But in terms of sort of basic principles, so there's 3 types of snake found in the UK. The adder, which is part of the viper family, is the only one that's venomous. Ideally, the aim is to try and get, if it's possible, to try and get some form of identification, so that when you seek medical services, they're able to get some clarification of what the animal was. So try and get a picture if you can. And if you have been bitten, certainly by a snake, it's definitely worth getting it investigated in case that there's a delayed response. That's if you don't feel unwell straight away. There's a very nice link here on Wildlife Trust website, which basically talks a little bit about the snakes in the UK and how to identify them. And then when I was looking through a literature review of snake bites in the UK and how they were treated, rather comically, one of the opening sentences was, "Most bites occurred in men who foolishly picked up the snake," which doesn't really surprise me, to be honest. So that's probably a nice soundbite of what not to do. Don't go trying to chase the snake bats for some revenge. In terms of my slides have decided, my whole computer decided not to work. I think our next slide is about what to do, how to manage it. So clinical features. So pain, swelling around the site of the bite. They may get some bruising and blistering happening. Skin color change. Vomiting, and then a state of shock may occur. Some of these are very similar to an adverse reaction to, like things like anaphylaxis, which we've already talked about. Poor pulse at the wrist. That's one of the features of shock. So that the blood isn't circulating around the body as efficiently as it should do. So you may have a weak, thready, or very rapid pulse. Might be all sweaty and clammy. Conscious level may be affected, and in some of the latter stages, it may affect the body's ability to form blood clot, and so you may find that there's a very excessive bleeding from relatively minor cuts or scratches. So these types of things are really, often treated on a similar line to allergic reactions. But there are a couple of more specific things just to mention about. So keep the casualty calm. Try and reassure them. It's obviously going to be a frightening experience. So the majority of snake bites are dry, so they don't cause envenomation when they puncture the skin. But obviously you don't know that until some time down the line when you've had time to reassess. Take simple paracetamol, so just as a pain relief and an anti-fever drug, avoiding aspirin and ibuprofen, as these can often exacerbate bleeding. Sometimes I think that the use of ibuprofen, I feel that there's all these sort of little things that we mention about ibuprofen that must make it quite complicated for you guys to work out what drug to give when. Ibuprofen often comes up as a bit of a warning. So it comes up as a warning in asthmatics. It comes up as a warning as patients who have undergone major trauma and are potentially bleeding. And here again, we're talking about snake bites and the fact that we don't want to be using ibuprofen. Ibuprofen is a really useful drug for things like musculoskeletal pain, so ankle sprains, injuries, upper limb fractures. These kind of things are perfect for ibuprofen. When patients are really quite complex and sick, it's a drug that does potentially have side effects, so it's often easy just to avoid it. But with paracetamol being a pretty much universally safe drug to give. So ibuprofen has the potential to catch you out in the real life and during your exam as well. In the event of someone being bitten and you're assessing them, what's really important is that you try and immobilise the casualty. So basically, lie them down and stretch them off. And the theory behind this is that it's supposed to reduce circulation of the tissues that contain venom, and so instead of the body pumping all that fluid lying around in the skin and in the soft tissues, that it doesn't do that, and it just reduces the amount of returning venom back to the body. The practicalities of that are obviously quite difficult, and the time frames we're talking about might make it seem a little bit silly, but this is what, if where possible, it's advised that you try and immobilize. There are some more complex things that like sort of types of compression bandage that some places do, but that has previously been recommended. But by and large, I think keeping things very, very simple. It's just a case of try and keep them immobile, lie them back, give them paracetamol, keep them calm. And then what's really quite an important point, and this isn't specific to snake bites per se, is it's that any limb that gets injured, whether it be an arm or a leg, the injury itself is going to put the body at a relatively high risk of causing swelling in that limb. So any sort of knock or bump or trauma or bite or whatever, and as soon as swelling happens in the limb, it can take time to reduce that. So if you see someone with a limb injury, or whether it not be a snake bite, whether it be a break or a sprain or a fracture or a dislocation, it's probably good practice to get into the habit of taking off any jewellery that is downstream of that injury. Just because, well, before any swelling sets in, if you get it off, if there's never any swelling, then you've not lost anything. But if swelling does occur, you're potentially saving worsening of an injury at a later point, or just a massive ball ache of a job for the A&E team, who have to then go through a laborious process of trying to intricately cut off these bits of jewellery, which can be quite time consuming. So yeah, that's just a general comment. So let's do some questions, and again, because I can't see you all, because of the way the screen's set up, I just to make it ever so slightly more interactive, so I know that either not everyone's asleep or that you've actually all just gone out for dinner and I'm talking to myself. If you just unmute yourself and shout out some answers, it would be most welcome. So let's just go through some questions, a couple of questions now. So a man is out walking on the Clwydian Range on a hot day. He experiences sharp pain in his right ankle. He looks down to see a snake biting his ankle before moving away into the undergrowth. 2 puncture marks in keeping with the location of the snake bite can be seen in the skin. He calls for assistance as to what to do next. What's the best course of action? So number 1, it's probably a dry bite, and either way, it's probably a grass snake. Offer reassurance and ask him to attend medical services. Number 2, inform him to lie down in a safe open area, take paracetamol, advise MR attendants to immobilise and carry off the hill and monitor for signs of airway compromise. Or 3, advise him to try and hit the snake with his walking pole so we can identify it, and then follow the steps to answer 2. So who wants
Number 2.
Say again?
Number 2.
Number 2. Anyone want to be heroic and go for number 3?
Well, I mean, number 3 surely is the first stage in your Dr. ABC, is getting yourself out of danger. So
very nice, yeah, that's a very fair point. Yeah, so I mean, it's interesting. But you know, I did some work in Costa Rica with snakes, and at that stage, everything was a little bit like, if you got bitten there, you know, you pretty much thought that your chips were cooked, and so everything got taken really seriously. And before I started to look into this, I'm not entirely convinced, that I would have necessarily taken all of this so seriously. And if someone gets bitten, you know, out like on Mulvamai, which is our sort of local set of hills, you know, the thought of, you know, lying them down for an hour and a half while our team drives up to them and driving them down to A&E, and where, you know, on first principles, I probably would have thought this was slightly all a bit of an overkill, but I guess it's just one of those things that you can't really take the risk. So yeah, I think number 2 is correct. I agree. Number 3 would be breaking the first principle. Anyone else any thoughts on that?
Just for your info, there is a adder colony in Loggerheads,
Okay, well,
right by base.
we will all avoid loggerheads from henceforth.
Very,
Training at base is now abandoned.
very, very small colony, and it's well cordoned off and away. But we had a large debate a while back about antivenom, but obviously antivenom's short lifespan and massively expensive. So, and it wasn't deemed necessary. But yeah, just to put you in case, there is adders very, very close by actually.
Interestingly, when I was in Costa Rica, the rules didn't quite apply, and actually the local guides who thought it was hilarious how scared the Westerners were of snakes. If there was a bite that happened, and the guy just ran over with a machete and cut the head off the snake for identification purposes, so they weren't quite equipped with the Dr. ABC code, but it was quite a heroic act, and it was actually quite useful. So fair play, but we don't advise that. Next question. So the same situation above occurs, and this time there's no snake, but there is a mark on the skin. There's pain around the sides of the ankle. The casualty is allergic to wasp stings. He carries an EpiPen. He informs you that he's beginning to develop difficulty in breathing with a wheezy chest. His lips are swelling and he has a rash over his body. Assuming in this situation that we will mobilise the team to assess him urgently, what is your next step? So number 1, he might have been bitten by a snake. He must lie still and await medical review. He can take paracetamol but should remain as immobilised as possible. Don't administer EpiPen as this isn't snake bite treatment. Number 2, he's been bitten by a wasp. He's allergic and is reacting to it, and so must be a wasp sting. Administer adrenaline. Number 3, it doesn't matter if it's a snake bite or a wasp sting. He's developed acute onset of breathing difficulty after being envenomated by a creature. He has known allergies. All bites can cause allergic reactions. Therefore, if this was a snake, you may be having an allergic reaction to this. Administer adrenaline.
Number 3.
Yeah.
I think I've intentionally worded this to make it sound like a bit of a common sense thing. But I think the point about this is it's all about in terms of some mountain risk attack medicine. It's all about just being pragmatic and just using a common sense attitude. You know, what it is you're bitten by is relatively irrelevant. You know, if they're, you know, it's all about just doing simple things well. And if we can identify the reactions of an anaphylactic reaction, which is severe difficulty in breathing, swelling around the lips and the mouth and the face that are potentially going to obstruct an airway. The finer details of what's going on aren't that important. You know, we're going to give them oxygen, we're going to give them, we're going to administer adrenaline, and we're going to treat them regardless. So that's about it, really. Any questions about bites and things? Like I said, I'm sure many of you have got far more experience or knowledge about the critters that creep in our land than me. So if anyone's got anything they want to add, please feel free to.
Anybody seen anything about spider bites this country?
There was something about false widows, weren't there, Pouch?
Yeah, there was. That's what I was getting at. I'm just wondering what false widow bites are like with people who are allergic, who would normally be anaphylactic to
Yeah, I don't know.
stings and stuff, and whether or not something that's deemed as medically significant, like a noble false widow bite, would or could trigger the same reaction.
Yeah, I think the short, the really short answer is I don't know. But I think that the pragmatic answer is that
You treat it the same anyway.
Yeah. So if someone has a bite and they're sat there and nothing's happening and they feel absolutely fine, we just sit there and we don't do anything with them. You know, you treat them as if they've been bitten by either they've been stung by a nettle or they've been bitten by anything that wasn't that important. You know, you just give them some paracetamol and keep an eye on them. You probably wouldn't do that for nettle sting, but you get my drift. Is that if there's nothing exciting happening, we don't do anything exciting. But I think that your point, I think that there's absolutely a real chance that there might be some. I suspect that the antigen from the wasp will be very different, but I don't know that. And what I would probably say is that if someone's got a tendency for an allergic reaction, I'm going to have them on a higher alert in my brain that they may have allergic reaction to something else, just because the way their immune system works. So I would be ready that if they did have a bite from something that I didn't know if they were allergic to, I'd have them under close observation, and I'd be sort of prepped if they did develop anaphylactic symptoms.
Cheers, Pat.
Cool. Little comment on we really are chopping and changing tonight. So apologies for the. This is why if you've got a question about a certain topic, you've got to ask it at the time, because we're going all around the houses. With a range of topics I've just listed from the syllabus. And one of the aspects that the MREW syllabus wants you to know about is the significance of extremes of age. So essentially we're talking about very, very young people and very, very old people. Now, very, very young people, we may see out and about, families going out for walks and this, that and the other. I think I think it's probably more common that we're going to see sort of independent older people out walking and causing themselves harm. The advent of electronic bicycles mean that old codgers can get pretty much wherever they want to go now, which is great, but obviously it puts slightly frailer people in slightly more complicated places should they become injured. I've got relatives that go mountain walking in their 90s, and they're still very fit. So there are lots of people who are wandering the hills, whose bodies may not be able to cope with a relatively minor insult like ours would. And they may react differently, and we have to be mindful of this. So what do I mean by this? So they may have different parameters. So this probably affects sort of more children than anything. So children tend to have faster heart rates, tend to breathe more quickly. That's probably, I think, where I was going with that. In terms of, and then as a result, not a result, but as a side effect, there might be different weights. So children are often smaller and weigh less. You'll notice from the Cascare syllabus that dosaging is often done around, rather than weight, it's done around age. So this became very apparent to our team with morphine when we were reviewing it this year, and we realised that to be able to accurately inject, I don't know if you remember, Pouch, if you remember the lower age limit of the children that were allowed to stab with needles, but it's like, can you remember how small we can stab kids with needles?
I can't remember off the top of my head.
I think it's about 7 years old, isn't it?
Fine, yeah, that sounds about
It's
right.
around 7.
I'll have a look in a sec.
So when you look at the syllabus, and I'd be interested to know whatever other teams we've got here with us tonight. I think there's some Clanberis team members here, but when you look at the syllabus, they talk about administering, 2.5 or 3 milligrams of morphine. I think some of them are even smaller than that. So when you're trying to administer a quarter or 15%, so that'd be 1.5 milligrams of a 1 milliliter vial of the drug, i.e. 1 mil of 10 milligrams of morphine. Unless you've got the right kit to do it, it's actually quite difficult to do. It's actually near enough impossible to do it accurately. So we've had to adapt by changing the size of our syringes so we can do it with more accuracy. Out of interest, anyone from any other teams, is this something that you are? How have you approached this problem with the syllabus? I'm sure says that for children under, I think it's about somewhere between 6 and 8, it's a really obscure number of milligrams of morphine. Is this something that you've discussed, or is this something that you're aware of what the process is?
I think the people from the Clanberis team that are on here are all kind of new to this.
Okay.
So, it's first time for all of us to be doing it. So it might be something, but nothing that we're currently aware of.
Okay, fair enough. So essentially, I think you guys also used diamorphine as well, which makes it a little bit difficult to cross compare. But essentially, the majority of teams will give morphine, and it comes in a 10 milligram vial. But if you want to give a fraction of that, you have to give quite small volumes, and to do it accurately, you need slightly different kit. So we've got around that our way. But anyway, that's another aspect of extremes of age. Another thing is that especially in the older category, they may be on a range of drugs, and that's important for number one. The drugs may alter their response to insults on the body. So what do I mean by that? So a lot of patients who have got heart conditions, a lot of patients who have got high blood pressure may be on drugs that lower blood pressure or lower the heart rate or prevent the heart rate from getting too high. Tablets called beta blockers. So it may well be that their ability to mount a fast heart rate is actually quite limited. So they're kind of blunted in the way that the heart rate would respond to, say, blood loss as an example. So if you lose blood, you're losing circulating blood volume in your body, and as a compensate, because there's less sort of volume in it, your heart pumps quicker to keep that same volume circulating around more quickly, so you're delivering the same supply of oxygen. Now, if you're on beta blockers that suppress your heart rate, then you obviously can't mount the same heart rate response. So you have to be ever so slightly cautious, that if they're on beta blockers, and I appreciate, I'm not expecting everyone to know what beta blockers are, but what's important is in your ample history that you get a list of the drugs, and then you call down for medical help if you're concerned, so that you can get a medical professional to explain the drugs to you and tell them how it might be affecting your assessment of that casualty. Because you're clearly not going to have a list of the thousands of medications that are littering the drug market. So that's one aspect. Another aspect is that they may be on drugs that actually make their injury worse, and a really common example for that is blood thinners. So from relatively simple low-dose common drugs like aspirin to other blood thinners, which I won't bore you with the various names of, but things like warfarin and some of the newer alternatives to warfarin. These can make any small cuts or bleeds, either external or internal, really take a much longer time to stop bleeding, so you get higher amounts of blood loss that we have to take into account. And then that's always important for sort of diabetics, so they're on tablets that are lowering their blood sugar, sometimes insulin, which is an injectable way of lowering blood sugar. And if they're out in the cold, lying, waiting for recovery, injured, and they've got drugs on board that are pushing down their blood sugars, it's something that we need to take into account. They're also their heart, their lungs, their blood vessels, everything just works differently. If it's been around for 80 odd years, it's less efficient and works less well than if it's been around for 40 years. So big sort of stresses of big amounts of blood loss, big amounts of trauma, just get dealt with less successfully, potentially, as we get older. So it's just something to be aware of more than anything. Anything anyone want to add, or anything that you want to add to that section?
Just going back to the morphine for children, latest formulary, our lowest age limit is 6 years old, and that's 2 milligrams.
Okay, so 2 milligrams. So 2 milligrams is 1/5 of a vial of morphine. So that's 0.2 milliliters. For those. It
gets harder when you get to like 7 and 6 at 2.5 megs, which getting that 0.5 is going to be difficult if you've got the wrong syringe.
So the way we've got around that is that you use a really, really tiny syringe. so that you can administer more accurately dosages, and that's what we've done. At some point, I'll ask Dan what Pharmaris do. I'll be interested to see what they do with their drugs, because you obviously carry different drugs to us. Right. So we're now at a slight juncture where we're going to go down the path of discussing a whole load of medical style problems, so heart attack, asthma, anaphylaxis, or we're going to go down another path and look at injuries to limbs, so breaks and fractures of bones. Does anybody want to stick their head above the parapet and say which one they'd rather go for? It's all going to be done at some point.
Any Patrick, go for it.
All right, fine. I'll just crack on. Stop asking questions and just crack on. So, important medical. Sorry, this is 6 years out of date, but I'm sure we can appreciate that it's hopefully all the same stuff. Ooh, we've got a disclaimer. Oh, right, okay. I didn't write these slides, but I'm just using them for to save me rewriting the book, as it were. So these are the medical topics that are going to protect you. So these are the 6 main medical topics that are a reasonable chance of coming up in your exam. I'm trying to think if there are any other ones, and I honestly. So overdose is probably one we should add in here. So there's these 6 plus drug overdose. That's probably another thing we should mention. There's not really much else. So if you can nail these 6 plus overdose, then you your medical scenario with a primary survey is kind of wrapped up, really. So let's get cracking. So case number 1: you're providing cover for a mountain race. A member of the public comes running over to you to tell you a woman's collapsed at the cafe. On arrival, a middle-aged lady is lying unconscious on the ground. A friend tells you she's been well a minute ago. She was sat having a lunch she'd bought at the cafe before collapsing. So you do your assessment. So airways patent, respiratory rate's 30, so that's high. Saturations are 90%, that's low. You listen to the chest, and the air is moving into both sides of the chest equally, and there's some wheeze on the chest. You feel for the pulse at the wrist, and you can't feel it, so that's suggestive of low blood pressure. You feel the pulse at the neck, and there is a pulse there. So, roughly speaking, it's not that accurate, but as a rough guide, blood pressure at a wrist. If you can feel the blood pressure at your wrist, if you feel the pulse at your wrist, you're thinking about a blood pressure approximately 90. Okay. There have been some studies into this, and it's not completely accurate, but it's a reasonable ballpark figure that if you can feel a decent pulse at your wrist, then you're going to have a blood pressure probably over 90. So that can be quite reassuring. If you can't feel a pulse at the wrist, then firstly try the other wrist, because sometimes people have differences in their pulses for a variety of reasons. If you can't find a pulse at the other wrist, then that's potentially a sign that their blood pressure is lower than 90. And if you feel comfortable or trained to do so, then you can therefore feel for the pulse at the neck. And a pulse at the neck, you're looking for a blood pressure of around about 50 to 60 to try and maintain that pulse. But this lady feels peripherally quite cool to touch, so she's not circulating blood around well. Well, we know that because her radial pulse isn't that palpable. Her heart rate's high, so that's a reflex mechanism from the body. So clearly something's going wrong, isn't it? So the heart's trying to compensate by squeezing more and more times a minute, so that we're getting more of the good stuff to where it needs to be. She's unresponsive on the floor, and her blood sugar is 7.3, which is fine. So anything over 4, we're going to be quite relaxed about. So we'll see where we're going with this. Oh, we're going to anaphylaxis first. Okay. So, okay, interesting. So, if I was going to add, I would say there's a little bit of a slightly unfair case. I think that there will be more pointers for your exam. I don't know. I don't know. I mean, please speak out. But I'm not saying that at the moment will be jumping out to me as anaphylaxis. I think there's anaphylaxis up there, but it's not exactly barn door. I think that for the purposes of your exam, you could be reassured that they're going to say something like, she was given a chocolate and peanut bar by her mate, or she's got a medical alert bracelet saying I'm allergic to nuts, and she's got a bag of peanuts in her hand, or they're going to talk about having a rash over the body or some swelling around the face. So I think that this case can be dressed up a little bit more, and for the purposes of your exam, I do think it will be a little bit more obvious for you. In case you were looking at that thinking like, shit, I wouldn't, why are we calling it anaphylaxis? I wouldn't be too worried. So anaphylaxis, definition, so it's a rapidly evolving and often dramatic condition precipitated by a recent exposure to a substance to which the patient is allergic, and they may know that, or they may not know that at the time that they're exposed to it. So things like nuts, most people know by the time they're into young adulthood, that if they're allergic to nuts or not, they will have been exposed to it. What does this mean for mountain rescue? So they get sick very quickly, they need to be treated very quickly, have a high index of suspicion, and the history, you can't see that because of where the recording box is, but the history is vital. So we don't need to learn, I don't know if gosh knows why that's on there, but basically this is to say that the antigen, which is the allergic thing, gets hit by a load of cells, and the cells release a load of histamine, hence, if you can work the antihistamines to treat allergic reactions. And the histamine, this exaggerated histamine response makes you really, really sick really, really quickly. Common things that can cause it, all these things, I'm sure that you'd probably pick out of a list of things that could cause an allergic reaction. So how do they present? So life-threatening upper airway obstruction, so facial, oral swelling or stridor. So stridor is like a snoring noise. So it's a sign that all those soft tissues in the back of the throat are closing in around our airway. We went into a bit of anatomy about the airway and detail about airway anatomy last week, but they're closing in around our airway, and they're causing this snoring noise as we're breathing in. In terms of B, there might be a life-threatening lower airway obstruction. So again, looking at last week's anatomy, we've got our big tubes at the top of our airway, up and around our mouth and in our throat, and then that breaks off into these vast amounts of little branches and tiny little air sacs, which constitutes our B section, and you can get a reaction to the lower airways that can cause a life-threatening reaction, and that will often present with things like wheeze, so sort of the typical asthma attack type sounds that you might experience. The respiratory rate will go up, and if the oxygen levels start to drop in the body, they might get what we call cyanosis, which is basically turning blue. C, so you might then get a life-threatening circulatory problem, so anaphylactic shock. So this is where, if you imagine all the blood in the body is contained in this one system, your bloods and your arteries and your heart. Now, the arteries and the veins can all sort of dilate, and if all the arteries and the veins dilate, and you've still got the same amount of volume inside those arteries and veins, and the pressure is going to drop, and that pressure is your blood pressure. And if that happens, your heart rate's going to rise, your blood pressure's obviously going to drop, so you're going to feel that weak pulse at the wrist that we talked about. They might become dizzy because the pressure's falling, blood falls as gravity draws it away. So if you stood up or sat up, the highest part of your body is your head, so blood will start to drain away from your head, and you'll feel dizzy. You might begin to sort of black out. That's the loss of vision side of things. And then eventually, as that gets worse and worse, you may lose consciousness altogether. And from a D perspective, rash, urticaria, which is sort of like this itchy sensation all over the body, vomiting, diarrhea, these are all common things. So essentially, anaphylaxis can happen with an airway problem, a breathing problem, a circulation problem, or a problem to do with D, as we've discussed, or quite commonly as a combination of all of the above. So these are all the things that we really worry about. So from an airway point of view, upper airway obstruction or impending upper airway obstruction. So we hopefully might get to them before their airway is closed, because if the airways become closed, then that's pretty bad news, because there's no way we can get oxygen down into the lungs. So we want to get to them before the airway closes, if possible, and give them suitable treatment. B, as we've discussed, wheeze or low oxygen saturations are an indicator of a B problem, and then a low blood pressure or no radial pulse is an indication of a C problem. But these are all time critical problems, and these are all patients that are time critical, so they must be treated quickly, aggressively, and evacuated ASAP to somewhere that's got extensive medical support. In terms of from the history perspective, ample is, it's part of your primary survey, that's a given, but obviously of importance, it's what are you allergic to? So not just drugs and tablets, it's are you allergic to anything, you're allergic to anything that they may have come across. So types of food stuff, obviously being the likely one, so nuts, shellfish, etc., etc. Is there a history of anaphylaxis? Are they wearing a medical alert bracelets, one of those little silver chains around the neck or the wrist that say that I'm allergic to this? If you find me unconscious, please do X, Y, or Z. It's always worth looking for these in your exam and in real life, because there may be clues hidden around. That's about it, really. Alternative diagnoses, well, asthma. So asthma has got a bit of an overlap with allergic reactions. So part of the mechanism and some of the symptoms you might get are similar. So an acute asthma attack, where all those lower airways are becoming very tight and wheezy, is obviously similar to a B problem in anaphylaxis. So a bit of a spectrum of conditions there. So if someone's very wheezy in their chest, it could be asthma, it could be anaphylaxis, but realistically, if it's just a B problem, let's give them some salbutamol, some oxygen, and if we think it's allergic and there's some facial swelling, then it may be a time to give some adrenaline. But we could, and then any sort. I won't go into too much detail. I think I'm going to confuse you if I start going through all these lists of other problems. So treatment, so doctored ABC, lie the patient flat and raise their legs. This is a really important principle for anyone who's what we call shocked. So their blood pressure is low, and their circulating volume and their pressure is too low to sort of maintain normal bodily function. So if blood pressure is low, I'm sure most of you will experience low blood pressure yourself. If you stand up too quickly, get up in the middle of the night for a wee and you jump out of bed, walk across the bedroom, and then suddenly you're feeling yourself a bit all woozy, you feel like you might pass out. That's probably because your blood pressure at that stage is, probably about 70 or 80 or maybe even lower. And then one of a couple of things will happen. Either your body will, because you're young and fit and healthy, will just recover and respond to that response by increasing your blood pressure. Two is that you'll sit yourself down because you feel like shite, and you'll you know that sitting down will make you feel less lightheaded. Or thirdly is that you'll lose consciousness, you'll pass out, and by passing out you end up lying on the floor where your heart is the same level as your head, and no longer is your head being deprived of blood supply, and you regain consciousness. So what this technique does, and this is useful in the case of anaphylactic shock, where blood pressure is low because of because of the anaphylactic reaction, or hemorrhagic shock where blood pressure is low because of lots of blood loss. This is a really useful technique. So lie them down, stick their legs in the air. The legs have got this huge capacity of blood volume, a couple of litres, and you just sink that straight back into the chest and the head where it improves the blood flow there. Obviously the chest and the abdomen and the head are far more important than legs. Put lots of high flow oxygen in them, so if they're going to lose their airway, make sure they lose it with all their blood full of as much oxygen as possible. It buys you a lot more time. And then give adrenaline. So this is an intramuscular injection, and we give it as the dose is there. But have a look at your medication. You always check the dose before you administer it. And then and you can repeat the dose after 5 minutes if there's no improvement, or there's improvement but then symptoms worsen again. If a casualty has an EpiPen, use it. I think that's a very fair point. And if a casualty can self-administer their EpiPen, I think that's entirely reasonable to do so as well. They probably will have been trained better in its use and may well have administered adrenaline far more times than we have. So they know what they're doing. If they're well enough to do it, we can take their lead. Any questions?
But not at the same time as giving our adrenaline.
Yeah, it's
EpiPens contain adrenaline, so you don't give both at the same time.
Yeah, it's an either or. Either we give them adrenaline, or they give them adrenaline.
Just in case people don't know what's in an EpiPen, that's all.
Yeah, definitely. Additional treatment. So as I said, there's overlap with asthma. If they're wheezy, give them salbutamol. Don't forget exposure. So if they've still got that peanut and chocolate bar hanging out their mouth, might be a good idea to get that out of there. And then monitor closely. So this is what we call biphasic response, where you get this peak, you treat it, and it drops down, settles, and then you get a second response several hours later, where they then have a further reaction. So generally, if someone comes into hospital with an anaphylactic reaction, they generally get watched for 6 hours. So if they come into hospital and we fully resolve their symptoms, they generally have to stay with us for a minimum of 6 hours, because that's often the time of this what we call biphasic response, where they potentially could deteriorate again. Then evacuate, which I'm sure is pretty obvious. Any questions on anaphylaxis?
No, just on that one, Patrick. You said helicopter would be appropriate. Is that more for if they're having breathing difficulties?
I think if someone has had any form of true anaphylactic reaction, certainly if anyone who has received adrenaline as a treatment, I think that they go into a very high category of casualty, and I think that you should be pressing reasonably hard to get them evacuated as quickly as possible by whatever means is appropriate. So if someone's had an anaphylactic reaction, say on top of Movali, I would definitely say, but they're okay, they're stable, they're settled, I would still be requesting probably for a helicopter response. And it may well be that the response from the other side is that actually we've got other stuff that's at this stage higher priority, and that's fair. Because the situation might change, but the very last thing you want is someone with a severe allergic reaction who's having a reaction is anywhere other than in a hospital. So I think it would be a reasonable request. Certainly, if they've got to the stage where they've received adrenaline, you need to treat them as a very sort of potentially critical casualty.
Okay.
If I'd have seen that taking the first call, I would be screaming for a helicopter before anything else goes on. That's how you take it. If you see upper airway and those sort of effects, then you ask for the helicopter first. We can always stand them down en route, but it would be the first thing in my mind.
Well, it's time critical, I suppose.
Potentially before starting the team off.
The other advantage is that helicopter team will have will potentially have advanced airway skills, this is one of the mechanisms by which patients may die. So you want someone with quite advanced airway skills to be around in this situation.
Would they use something other than IM adrenaline then? Would they give it IV?
No, so it can be given, but intramuscular adrenaline would be used by any service as a first line treatment. But they might do other things. They might put a cannula in and give some intravenous antihistamine. They might give some intravenous steroid. But in intramuscular morphine. Intramuscular adrenaline remains the first line treatment for whatever skill set is present.
Okay, cheers.
Any other questions on anaphylaxis? No? Fine. Okay. So case 2. I'm just going to keep wittering just so we can cover content. People need to drift off. Please feel free to. If generally everyone's starting to flag, just tell me because and let me know. I honestly don't mind. It's not the most wild way to spend a Thursday evening. Right. So case number 2. So I'm not sure what this is. So you're providing a cover for a canoeing event. It's a warm summer's day. A paddler's recently got out of the water having completed the course. He's noted to be wandering around the car park. He's confused and agitated with slurred speech. So our doctor's ABC assessment, so airways patent, respiratory rates okay, saturations are okay, chest is equal air entry, he's got a good radial pulse, so we know his blood pressure is above 90. He's peripherally warm, so his hands are nice and warm, so blood's circulating the body well. Heart rate 74, that seems acceptable, doesn't it? He's alert, his blood sugar is 3.2. What was the number?
It's a bit low, that.
Oh, say again?
It's a bit low, that.
It is.
It's below 4.
It is. So,
Very low.
So four is the number that we're going to be pretty unhappy with. That's beneath that. So now we come on to the topic of hypoglycemia. So hypoglycemia is a bit of a mimicker. So it can mimic all kinds of different medical problems, and it's very, very subtle. And just why some of you may have heard the acronym ABCDE and then DEFG, don't ever forget glucose. This is why. So it can present with lots of strange symptoms, and it can be notoriously difficult to get to the bottom of, despite it being really, really simple to test for. And I've seen some really wacky presentations of hypoglycemia that I would have never have sought out previously. So good rule of thumb. Just check a glucose. There's absolutely no harm to not do it, especially with someone with neurological symptoms, so confusion, drowsiness, low conscious level. These are really critical times that you need to check your blood sugar level. So, really bit of a cerebral slide. This liver's important for sugar, pancreas is important for sugar. It all rotates around. That's pretty much all you need to know. Diabetic problems. So there's quite a few categories of diabetes, but there's two very, very broad types of diabetes. So type 1 diabetes is where the body's immune system attacks itself and actually, you know what, I was being a bit too flippant. Maybe I should just go into this in a little bit more detail, otherwise I'll regret it. Essentially, sugar lives all around the body. It's stored in the liver, but what happens is that where the sugar needs to get to is all the cells of the body, where it is then used in a variety of chemical reactions to form energy. Now that happens by insulin sending sugar from the blood into the cells. Okay, so if you don't have insulin, then what happens is that all the blood all the sugar stays in the blood, and it doesn't get to the cells. So the cells aren't getting that sugar to provide energy. Does that I hope that kind of makes sense. It's a very, very simplistic but quite an accurate way of doing it. So insulin gets sugar from the blood into the cells. Now, if you're a type 1 diabetic, you don't produce over time. At some point in your childhood or in your teens, you stop producing insulin. So you get this build-up of sugar in the blood, and you become quite poorly quite quickly. And these patients, type 1 diabetics, diagnosed earlier in life, they'll be on insulin for life because they have to replace all their insulin. I hope that makes sense. So a patient will know whether they're a type 1 or a type 2 diabetic usually, and certainly if we're seeing patients out on the hill, if they're with a school group, if they're in their teenage years, if they're younger, then it is likely that they are a type 1 diabetic. Not always, but it's likely. And there, for them, insulin is super important. Type 2 diabetes is slightly more of an adult onset diabetes. It's usually due to a variety of factors, but basically their body is less sensitive to insulin, so they still make insulin. It's just that the body, for a variety of reasons, often maybe due to diet and lifestyle, means that the body, there are other reasons. If anyone here is type 2 diabetic, I'm not trying to label in any particular way, but often it's due to the body becomes less sensitive because it's been almost challenged a lot over years of requiring lots of insulin because of high sugar. So what happens is that in diabetic problems is that you can have one of two things. So you can either become hyperglycemic, so hyper being high, where the blood sugar in the blood is very, very high, or hypoglycemic, where the blood sugar in the blood is very, very low. Now, hyperglycemia can be a real problem, and it can be a problem acutely, but it usually doesn't just creep out over a matter of hours. It usually creeps out over a matter of days. So if someone's really sick from hyperglycemia, it's probably unlikely they're going to be out walking in the hills. It's possible, but it's unlikely. And either way, if the blood sugar if the sugar is high in the bloodstream, at some point they need some treatments to get it back into the cells, and we don't really carry that treatment, so we're not going to be offering them treatment. Hypoglycemia is different, so this can happen quite acutely, quite quickly. It can happen over a matter of half an hour, and it can lead to very, very dramatic consequences. It can lead to seizures and even death if not treated promptly. And this is something that we can actively treat and should actively screen for. I've already mentioned that there. So hyperglycemia, so high blood sugar, drink plenty of clear fluids, not obviously Lucozade or full fat Coke, you're just going to make the problem worse. Water, basically. Get water into their bloodstream, they can peeing it out, and ask them to seek medical advice either with a GP or A&E if needed. But hypoglycemia is what we're really going to try and focus on because it's very easily treated and can very easily cause harm. So they might be unsteady, they might be confused, they might be sweaty, they may just be not quite right, their personality might have changed, they may be very, very hungry, and they may begin to seize. If the patient's unconscious, then you're usually looking at a blood sugar level that's quite low, so 1, 2, 3.2. I would not expect to make you unconscious, but certainly between 1 and 2 is likely to affect their conscious level significantly. But obviously it becomes a little bit muddy the waters, because if someone has just got a reduced conscious level, that isn't specific for low blood sugar. There's other things that cause it. There's a head injury, they've got a bleed in the brain, and the brain is all suppressed and isn't working properly. Or they may have had an overdose from a drug like morphine that suppresses their conscious level. So what we're going to do, same as always, primary survey. If they're conscious, there's a concept of slow release and fast release sugars. So slow release sugars is basically where the sugar is in its simplest form, a bit like a dextrose tablet or like an energy gel, where it's just quick release sugar. By the time you've eaten it and it's in your tummy, it's already being released into the bloodstream. And kind of to a degree, sweets and chocolates also fall into that category. And then you've got a more slower release carbohydrate or sugar, things like sandwiches, bread, potatoes, which break down slower and give a more prolonged release of sugar. So it's not really that helpful to get you out of a quick fix, but it can be useful to give them a fast release sugar straight away, bump up their blood sugar, and then at the same time give them a prolonged release carbohydrate like a sandwich. So that means that you've got your first maybe half an hour, 15-20 minutes covered with the glucose gel, and then after that, your sandwich might be starting to kick in, and a couple of hours later you're still getting the effects from that sandwich, if that makes sense. But quickly, basically, glucogel, quick release sugars, get that in as quickly as possible, and keep checking your blood sugars to make sure they're rising. Some teams might carry glucagon. That's a hormone that can be used. I think I've got some in my kit, but I've never used it. And it's not as part of the kit 2 drugs, so you wouldn't be expected to administer that. Once a casualty is awake, feed them fast and out. I've already said that. Any questions on low blood sugar?
Just a note that it's once you give them that fast acting gel, rubbed it around my gums or whatever, and your casualty's back talking sort of semi-sense again, talk to your casualty, because they've dealt with it in the past. They know what is preferable for them and what they tend to take, whether it's a Mars bar or quite often it's a bottle of Lucozade. They know what brings them round and what is easier for them to manage afterwards, which is all part of the problem, is managing that glucose level afterwards. So if you talk to your casualties, 9 times out of 10, they'll know what their preferred come round is from a hypo. Vauxhall's, where I used to work, had a dinner meeting for diabetics at the surgery, and I used to go along and literally just talk to them from that point of view to find out, gain more information on the condition. And most of them said, "Yep, we know what brings us round." One of them loved Eccles cakes, fast sugar from the currants, and the pastry used to settle them down. Most of them said bottle of Lucozade, but do talk to your casualties, get the information off them.
Cool, yeah, good advice. Although it does remind me that this is what if we do for the conscious casualty, but it's worth mentioning, as Pouch alluded to, if the patient is unconscious, they obviously can't eat, so this is where we rub our glucogel sachets into the gums and it gets absorbed from between the gums. So glucogel is a group 1 kit drug, so all team members, all sort of Cascare should carry that individually by themselves, a couple of sachets of glucogel if you don't already.
So can I just ask a question, Patrick?
Yeah.
If let's say that they've had a diabetic episode and they're stabilised and they're up and talking, do they still go to hospital? Do we still just advise to go to hospital, or can they go on their merry way?
That's a good question. So what I would say is, if they've had a significant hypoglycemic event, certainly one that's impaired their conscious level, I would be keen to make them our responsibility until we can put them firmly in the responsibility of another healthcare provider, ideally. So be met with a paramedic, and if they want to discharge them, then they can discharge them. This kind of boils down to in the way that Pouch was talking, is that a lot of diabetics know about their condition very, very well, and they manage it themselves. And maybe some diabetics might be used to having a hypoglycemic event and they know how to treat it and manage it. So I think that we should advise them to seek medical services, but we can't obviously enforce it. If it was left to my decision, unless I was completely convinced that this was a really switched on person, had lots of support with them, was there with a group of 3 or 4 friends that were going to keep a really close eye on them, I think it would not be unreasonable for them to work out their own way out of this. If it was the first event, with someone who isn't particularly self-skilled in managing this condition, I would be keeping on to them until I got them somewhere safe, or got them to hand them over to someone who was going to look after them, and if that's like, you know, maybe their mum that was going to take them to hospital, or a paramedic, or whatever, these are the things that I would want to be satisfied. What I wouldn't do is, if it was someone who was relatively new to this, I wouldn't just give them some sugar, get their blood sugar normal, and tell them to crack on with their day.
Yeah,
Just a note for your exam. Ask for a helicopter or walk them off. Stretcher them off. I know somebody on our team who failed as advanced because he said he was going to walk them off, and they failed him on the spot for it. Personally, I think they were being really harsh on it, but they can't fail you if you turn around and say you're going to walk them off or get a helicopter. If you tell them they're going to walk them off, then you potentially could get failed for it. So err on the side of the caution for your exam and say the team would extract them or ask for a helicopter, because they can't fail you for it. Because you're not wrong, but just err on the side of caution on it.
Yeah, that's fair. You can never be criticised for overkill. Yeah, definitely. Any other questions on blood sugar? Diabetes? No. Okay, right. I'm going to rattle through this case, and then we're going to take a welfare check and see whether you all fall into a hypoglycemic coma or not with listening to my boring, droning voice. Right, case 3. So you're out team training. You see a teenage girl. She's leaning forward on a picnic bench. Her breathing is laboured. She's very wheezy. So Dr. ABC, airways patent, respiratory rate 26. That's high. Saturations are 100% on air, so that's normal, isn't it? It's probably a bit higher than we might expect. Not everyone, most people run in the high 90s. And she's got equal air entry. She's got evidence of lots of wheeze. She's got a good radial pulse, so blood pressure is over 90. Peripherally warm, so body's circulating blood around nicely. Heart rate is 112, so that's a bit of an indicator that, you know, body's not happy. She's alert, the blood pressure BM of 5.9. So who does anyone want to comment on that? Saturations of 100%. So we've got someone here. Oh, go on. Go.
Is it worth checking the monitor and also wheezing? Is it worth checking your equipment for 100%? But then if they're wheezing that badly, are they just hyperventilating or what?
Yeah. I see someone else come off mute. I can't see who it is, but does someone else want to add a comment? No. Never mind. Yeah. So I think it's entirely reasonable to check kits if you see a result that's not quite expecting. I think in this context, I think that your comment about hyperventilating is right. So this girl's got a B problem. She's quite wheezy. Which sounds like it could be an asthma attack, doesn't it? I've never had an asthma attack, but I imagine it's absolutely terrifying. So her respiratory rate is going to begin to quicken. Her body recognises that there's a problem with her lungs, so it's going to respond in a way to try and drive everything as quickly as possible. So her saturations of being 100%, potentially at this stage, are probably accurate because she's overcompensating. Something bad's going on in the body, and so her body's breathing really, really, really quickly. So at this stage, her saturations are probably okay. But the worry is that this is a reassuring snapshot for exactly where we are right now. But as time goes by, all the muscles that get involved with respiration and breathing, they're all still the same type of muscles that exist elsewhere in the body, you know, in your legs and your arms, and they can get tired. So over time, as the body can't compensate with pushing up that respiratory rate and drawing in all these extra muscles in the chest and the abdomen to try and expand and contract the chest, draw in and out air, She'll get tired. This will happen less effectively, and her oxygen saturation will start to drop. And then you're kind of on the downward spiral, and you're kind of missing the boat. So this is a reassuring position to be in, but I wouldn't say oh, saturation is 100% on air, you know, on your bike. This is like the golden window where we can recognise there's a problem happening because the heart rate's pretty high, respiratory rate's pretty high, but she's just holding her own with a nice oxygen level. But we need to be conscious that the time, if we don't treat this correctly, that we might start to hit that slippery slope. Acute asthma. So as we talked about before, we've got all these different airways that align with muscle, and what can happen is this is a cut through of these little airways in the smaller tubes of the lung, and this is where if you cut through it, at rest normally without any allergic reaction or any asthma reaction, you've got all this big gap in the middle where air can move in and out. During an asthma attack, you get lots and lots of inflammation and constriction of the muscles that line the wall, and it contracts down and leaves you with a really, really small amount of space in the middle, and that's what causes that noise, that wheezy noise. So what can cause it? So things like hay fever or inhaling any pollutants into the lungs. Cold air can exacerbate it for some people. Drugs, so aspirin, beta blockers, or things like ibuprofen can trigger it for some asthmatics. Or people who are asthmatic who've got a chest infection, that can sometimes trigger it. So how they present, they're short of breath, they might be wheezy, they might be coughing, their respiratory rate might be high. Respiratory rate that was low would be a very, very worrying feature. Very, very worrying. It would suggest that they're a bit tiring to the point of failure. Oxygen saturations might be quite high, and then they might start to tail off, and that's a worrying sign. The heart rate is likely to be very high for multiple reasons. Predominantly, I suspect, due to anxiety and panic because of the symptoms that they're describing. But also salbutamol, which is a treatment that we're going to use for this shortly. Salbutamol is a really potent drug that increases your heart rate. So if you were to take a salbutamol nebulizer now, your heart rate would probably go up about 20 beats, maybe more per minute, just as a response to that drug, the way it works. And generally just have a look at them and see what they look like. And if they're sat up and talking and looking quite comfortable, you can be reassured. If they're kind of like, if they can barely get a few words out at a time and they're looking quite tired and worn out, then this is a big red flag. And this is it with asthma attacks, is that more often than not, these are well controlled, well managed, but when they tip over the edge, it's a very, very dangerous ground of quite quick deterioration that can lead to really, really serious harm. Don't want to get too much into classification, because I think it's potentially a little bit of detail that is unnecessary for you. But I think that the point they're trying to make here is that there's a few categories that you can use to determine how severe the reaction is. So are they speaking in full sentences? So are they, which is what it sounds like. So you can be able to complete a full sentence without having to take breath, a bit like I'm doing now. But if they're having to take a breath every couple of words, that is a poor sign that they're tolerating this well. A quick respiratory rate of, here they've used 25, is a bad marker, and a very quick heart rate, say over 110, is another bad marker. So if we go back to this girl here, we've got quick respiratory rate, we've got quick pulse rate. They haven't said whether she can talk in full sentences. I suspect probably not, but I don't know. Saturations are okay, and you notice that for the severity index, they haven't used saturations here because saturations are a bit of a late sign. If their oxygen levels are starting to drop off, that's a sign that we're on that downward trajectory. Here we go. So, all these symptoms or signs are, they're ones that are going to freak you out. Exhausted, confused, cyanosis brackets, that's what I mean by blue, you know, barely breathing, low oxygen saturations, very slow heartbeat, low blood pressure, or in a coma. Pretty sure we are all aware that these are all unpleasant words to describe how well someone is. So if these are happening with asthma, that's a big problem. Alternative diagnoses, I think the main thing here is that think about this overlap with anaphylaxis. But just don't forget with anaphylaxis, you know, we often might have a known allergic trigger, and there might be some skin changes as well, like we talked about before, so rash, swelling, etc. Panic attack, that's a very interesting thing to put in. So panic attacks are pretty common, and I'm looking at this, I'm trying to work out. There's only so all of it. If we took out wheeze, I would say that could easily be a panic attack. Sometimes people have panic attacks can actually wheeze slightly, but breathing quickly, fast heart rate, these are signs that can be seen in a panic attack. But it's at the end of the day, it's not on our pay grade to make the decisions on the hill. Our decision is just to treat what's in front of us, treat the worst thing that could be, and get them out of there.
Patrick, can I ask, with the panic attack, would the saturation levels be that high? Because the breathing that much, it interferes with your carbon dioxide levels, doesn't it?
So in the blood, obviously we've got, as you said, we've got oxygen and we've got carbon dioxide. So oxygen is the stuff we're sucking in to supply our cells. Carbon dioxide is the breakdown product from our cells that we're then breathing out. So if you have a panic attack and you hyperventilate, you're breathing air in and out and in and out and in and out. And what you're doing is you're drawing in lots of extra oxygen into your blood.
Yeah.
And you're kicking out lots and lots of extra carbon dioxide out. So what happens is that you end up with very high oxygen levels and very low carbon dioxide levels. So in short, the answer is you would see saturations that are quite high.
Right.
But it's a carbon dioxide that you might see being very low. And the main symptom you might see from that is that they might get pins and needles in their fingers or their lips. That's a sign that their carbon dioxide level is low, and that's one of these key signs of a panic attack that we see, where we use it as quite a helpful discriminator for someone who's having a panic attack. If they're hyperventilating, they get pins and needles in the fingers and the lips, and that's often why you may have seen people in films use a brown plastic bag to breathe into, and what that does is that recirculates the same air in and out, so you end up you're basically breathing back in more carbon dioxide. But we're not going to be doing any breathing into a brown paper bag or anything like that. So, but that's the theory behind it. Does that answer your question, Mandy?
Yes, it does. Yeah, and I think with the diagnosis you've got there, you've been to the casualty and that's what you've come across. It's a really good time to do your ample to get the information so that you can see what you're dealing with. You've got a better idea what you're dealing with.
Yeah. And especially while they're still able to talk to you, so you can get a clear history. Definitely. Yeah. So treatment, doctors ABC obviously set the casualty up. It's just nicer for them, and it allows all their respiratory muscles to work more efficiently if they're sat upright rather than lying down. Give them high flow oxygen. Don't worry about just chucking in as much as possible in the early stages. We can always dial it back at a later stage. And our drug of choice is going to be salbutamol. So we give it in a range of different ways. We give it as an inhaler, which they probably carry themselves, a spacer device, which is a really useful technique that can be very, very effective for children, which is basically a big plastic cylinder. You puff a load of squirts of salbutamol into it via an inhaler, and then they just breathe in and out of that container, and that nicely works. Or we use nebulized salbutamol, which hopefully that's a skill that you'll need for the Cascare, where you have to set up with an oxygen cylinder, and it sort of atomizes or vaporizes the liquid salbutamol, so they breathe it in. Always have a low threshold to go for nebulized asthma attack. In this situation, she's got a wheeze, the respiratory rate's up, heart rate's up. I'm just going to give her salbutamol 100%. Via a nebulizer is what I meant to say. I'm going to give it via a nebulizer. I'm not going to fanny around with some of the other techniques. Okay. So talked about a little bit about so this is the spacer that we talked about that this gentleman's holding. He's got the inhaler in his hand. He squirts 10 puffs into that spacer and then breathes in and out and in and out and in and out. And that's about it. Nebulizer, one of the skills hopefully you'll all be up to date with for your exam. So this cap turns off. This chamber is filled with the liquid salbutamol. You reattach it, and then you connect the oxygen at around about 6 to 8 litres per minute, and that's the right amount of oxygen, or most sufficient amount of oxygen to vaporize the salbutamol and give you a nice stream of vaporized drug, which you then inhale through the mask. And you evacuate very, very quickly. Any questions on that?
No, all good.
Okay. Right, what's everyone thinking? It's now. Oh, sorry, I was late. So we're up to an hour and a half now. Does anybody? Are people starting to flag? I'm happy to call it an evening now, or we can move on. Does anybody have any strong preference?
Have you got any plans for the rest of the night?
No, don't worry. Well, I'll grab some grub at some point. I heard someone else making a comment there.
That's all right. I'm working till 6 in the morning, Patrick. You can keep going if you want.
Okay. Well, I'll maybe just crack on till 9. But feel free to dip out, because I'm sure it's quite intense stuff. This just quite boring, if anything. So feel free to duck out at any point. So we'll just do another case or two. Take us up to 9 o'clock. So what have we got here? So we've got some more conditions, and then right, so let's crack on with this case. Just going to just the background noise. That's all right. Right. So medical problems number 2. And by chance, yes, we're coming on to the most important medical problem that exists, and that's a problem to do with the heart, which is my particular area of enjoyment. So,
I was about to say you're biased.
Yeah, indeed. So you're asked to see an elderly gentleman by his wife. I feel like that victimises heart patients, not all elderly. On arrival, he sat on a bench rubbing his chest. He looks pale and clammy, and he tells you he's got terrible heartburn after having a pasty for lunch. So we're going to do the boring stuff first. We're going to do a doctor's ABCDE. We're going to check his airway, which is patent. We're going to do his respiratory rate, which is a little bit up, 22. Saturation is 97%. That seems okay. It's not 100%, but it doesn't need to be. That's probably quite normal. Equal air entry, no added sound. Good radial pulse, roughly 90 millimeters of mercury. Blood pressure, that's good. Periphery warm to touch. We know what that means. It's good. Heart rate's 94. Bit on the quicker side, would you say? So it's not grossly abnormal, but it's a little bit higher than we might see. But he's elderly, and we talked before about different ages having different parameters. So we're gonna note that, but we're not necessarily going to do anything about it. He's alert, and his blood sugar is 9, so we're happy with that. So they've used the phrase ischemic heart disease here, which is not unreasonable, because that's exactly what it is. But in terms of reducing jargon, ischemic basically means reduction in blood flow to the heart muscle. Okay, so your heart is a big muscular pump. It pumps blood around the body all day, every day, hopefully, and as a big muscular pump, it needs its own fuel supply, and it gets that by your coronary arteries, which supply it with blood. And if those arteries become blocked, or narrowed, you've got a problem with delivering fuel to your engine. And if it happens all very suddenly, one of those arteries just suddenly blocks off, then very, very quickly the muscle downstream of that blockage is starved of oxygen, and you are having what's called a heart attack, or an MI, or myocardial infarction. But a heart attack will do for our training, and that's often associated with pain and discomfort. And the really sort of classic type of pain that they will often describe is a central chest heaviness, or pressure, or crushing, or tightness across the center of his chest that will often radiate up into the jaw, or the shoulders, or the left arm. They might be breathless with it, they might feel sick with it. This is like the textbook description, okay? Which if someone tells you this, which they will in their exam if they're having a heart attack, then you're like, bish bash bosh, lovely jubbly, nice easy description. In real life though, it's a little bit more grey. So there's lots of mimics for heart attacks. So the big one, especially in older people, is heartburn. Because they've had heartburn before, they refuse to believe anything actually severe is happening to them, and so they've got this really unpleasant sensation in the centre of their chest that they just put down to heartburn, and they often ride out their heart attacks at home. Ischemic heart disease is this reduction in blood flow to the heart muscle, and if it happens suddenly, so a blocked artery, that's what we call a myocardial infarction, or a heart attack, for simplicity's sake. Okay. If there's a narrowing of the heart artery that's been there for some time, so you've got, then what happens is that as the engine of the heart begins to exercise and pump quicker and quicker and quicker, it gets to a point where it's pumping, it requires so much oxygen and blood that actually the narrowing is just at that point starting to restrict blood flow. So for example, there might be a narrowing in one of those heart arteries, so you're walking along the flat, no problem at all. You walk up an incline, and suddenly the body requires a lot more effort, because walking up an incline is actually quite demanding on the body. And there's that threshold where the heart needs that extra oxygen, but that narrowing won't allow it to get there. And then they get what we call exertional chest pain, and that's what we call angina. And the crucial thing about angina is angina then settles, that pain settles when they rest. And there'll be patients who will walk up a hill, they'll get chest pain, they'll stop, the pain will go away, and they'll continue their walk. And that may be something that you may have seen relatives or people in your life experience. And these are quite two different processes. Many people live with angina and live quite happy lives. Heart attack or a myocardial infarction requires urgent treatment. But how can you tell the difference? If this guy's walking up a hill and he gets chest pain, how do you know that's just an angina attack, or how do you know it's a heart attack that just settled on its own within 5-10 minutes? You don't. So the short answer is pain in the chest that's led to you being called out to see someone. You're just going to treat it as a heart attack, and that's pretty much the end of the story. I hope that makes sense. A diagram of the heart. So big heart pump, lots of muscle, blood supplies to it. Normal artery that develops a little bit of cholesterol and fatty deposit as we live our Western lifestyle. Gets very, very narrowed, so less blood flow can get through. This is likely to cause angina, exertional reduction in blood flow, and then suddenly, if this ruptures, it basically everything clots off, blood clot forms, and that's why you're having your heart attack. So we've been over this. So central chest pain, heavy crushing, gripping, radiating up into the neck and jaw, indigestion-like pain, nausea, sweating, shortness of breath. Reasons why it looks, where we start to worry, as if they start to look cold, pale, clammy. That suggests that the heart as a pump is starting to fail. so it's no longer driving blood around the body effectively. Lots of wheeze or crackles in the chest, that suggests that the pumping function is failing and you're getting fluid on the lungs. Signs of shock or abnormal pulse rate or rhythm. So one of the more important features, especially for your exam, it's a really nice touch. For your exam, someone's having a heart attack, you specify that you're going to take with them a defib, because the risk of developing a lethal heart rhythm is quite high. Not quite high, but it's higher. And so you want to have a defib available to shock them out of that dangerous electrical heart rhythm should they go into cardiac arrest. Okay. Cardiac arrest, this is a term that often gets used synonymously with a heart attack, and there is a very clear distinction. Heart attack is described as blockage of a heart artery, so that the muscle doesn't get blood. A cardiac arrest is where the heart stops pumping, and that can be for a variety of reasons. It can be for electrical reasons in the heart, it can be due to mechanical reasons in the heart, but the cardiac arrest is where you're pulseless, you're not breathing, and we do CPR and we try and resuscitate them. Okay, so a tiny number of heart attacks might cause a cardiac arrest, but not all cardiac arrests are caused by a heart attack, if that makes sense. Just jargon bashing as we go along. Alternative diagnoses, could be some muscular pain, could be indigestion. We won't go into the rest of these. But what you're going to do, you're just going to treat it as what's more concerning. So Dr. ABC, sit the patient up in comfort, high flow oxygen. So this is slipped slightly, so I need to change this. So high flow oxygen if the saturations are less than 94%. So they've got normal oxygen levels. We aren't going to give them oxygen. If the oxygen levels are low, we are going to give them oxygen. Attached defibrillator pads. That's I'm kind of indifferent about attaching defibrillator pads. It'd be pretty bloody scary if you're having chest pain and some guy's strapping you on with defibrillator pads while you speak to them. My personal preference would be is that unless they look critically unwell, I probably wouldn't have the defibrillator pads on them. I would have the defibrillator next to me so that if something happened, I could have the pads on within 10 seconds. Again, you're not lost any time. You've got 10 seconds, whack them on. I think that, from my personal feeling, is that might frighten the patient and make it's not great patient care. But if you have the defibrillator next to you and you ask for it in your exam, then you're ready to go in a very, very quick process. If the patient looks rubbish and they're displaying one of those adverse features we talked about before, so signs of shock, looks cold, pale, clammy, abnormal pulse rate or rhythm, these are signs that we might want to think about with the pads, but I wouldn't do it routinely. GTN spray, so this is what we're going to use. This is the little red tube that spray underneath the tongue that works to relax the muscles in the heart arteries and tries to open up that blood vessel. Can cause a really nasty headache and make people feel quite lightheaded because it lowers the blood pressure. Aspirin, 200 milligrams of aspirin. Morphine for pain relief. It's worth mentioning that the reason why pain relief is important here is because pain leads to increased heart rate. So it is part of a reaction in the body. So if you're in pain, your heart rate will go quicker. Now, if you're a heart that's being starved of oxygen, the last thing you want is to be demanding more oxygen by being pumped quicker. So if you get rid of the pain, the heart rate will slow down and you're just requiring less oxygen on that heart. And then Buckistem, that's the anti-sickness that we often give with morphine to stop them from feeling sick at the same time. So this all bundles down. I know that my team will have heard me talk about MONA, the acronym. They bang on about it all the time and they're probably rolling their eyes about it at the moment. But MONA is quite a good acronym for treatment of heart pain. It's not written down here, but I'll just add it at the bottom. So morphine some people don't like Mona, but I think it's quite good as a teaching aid. Oh shit, I can't even spell Mona. So oxygen, and then N is for nitrate. And what is quite useful, because it breaks it down and tells you when you're going to give all these, when you're going to give all these treatments, because they're not all given to everyone. So morphine is given if they're in pain. Okay, if they're not in pain from heart, if they don't have any active pain while you're seeing them, they don't need to have morphine. Oxygen can be given if SATs are less than 94%. If SATs are greater than 94%, they don't need oxygen. And we've got nitrate, so that's a GTN spray, so GTN stands for glycerol trinitrate. So the nitrate tablet, a nitrate in spray can be given if in pain. If there's no pain, you don't need to give the nitrate. And then finally, aspirin is given to everyone. So if the pain's gone or the pain's still there, giving aspirin has been shown to make people live longer, happier, healthier lives in the context of having a heart attack. So we're going to give them the aspirin as per the formulary, which is a 300 milligram chewable tablet. And that's about it. So that's, I 2 sprays under tongue, repeat 5 mins if in pain, oxygen and morphine 5. So I quite like Mona. I think it's quite useful as a teaching aid, or just trying to remember what you want to go through, partly because it's useful in trying to break down who gets what. So everyone, so this man, so his pain's gone, so he had pain, it's now gone, he gets aspirin, he doesn't need nitrates, he's not in pain, he doesn't need oxygen because his saturations are normal, he doesn't need morphine because he's not in pain. Yeah. As it turned out, I was talking rubbish because he actually is in pain. So in which case, we're going to change that. So we're going to give him aspirin. He looks pale and clammy. Well, pale and clammy, well, we haven't got a saturation. Oh, do we have a saturations on him? We do have a saturation, so we don't need to give him oxygen. He's got pale and clammy, always a bit worrying. Pale and clammy in a trauma setting, or in any setting, often might mean there's low blood pressure. So that got me a bit worried then. But actually, we know he's got a really good radial pulse, so it's probably reasonable to proceed that he's got a good blood pressure. In which case, what would I do for him now? I'd give him 2 puffs of GTN under his tongue. Sorry, I've lost my Mona. Give him 2 puffs of GTN under his tongue. I'd give him 2.5 milligrams of intramuscular morphine. Reassess in 5 minutes and change and add more if needed to after checking his primary survey again. Any questions on that? Any comments? Anyone want to change what I've said or add anything different?
Only about the GTN spray, that a lot of patients that are diagnosed with angina carry their own GTN spray. Double check, triple check that your casualty hasn't already taken the GTN spray before you wade in and then start giving. I've seen it done, and some poor guy ended up with 4 doses of GTN spray because they hadn't actually checked to see if he'd taken his own, and then they went wading in and sprayed him with their own. So the guy ended up with a massive headache and a massive low blood pressure. So do check that they haven't taken their own before you start giving them.
Yeah, and I suppose that brings us back to the purpose of an ample history. So you need to check all this stuff, get a close history, and really tide out all this stuff beforehand as well, and really nail people down. Of note, the nitrate, the syllabus refers to people being on a tablet called sildenafil, that this contraindicated to. Sildenafil is Viagra. Although women can be on Viagra for a variety of reasons, it's just worth knowing in case it surprises you by the exam that if someone says they're taking Viagra in their exam, it's unlikely that they're going to be that mean to you. But if they're away for a good old weekend hiking in the hills with some Viagra, just be careful about giving nitrate because it is specified in the syllabus, in the formulary, as a contraindication to giving the nitrate medication.
And aspirin. Aspirin goes to everyone regardless of what they've taken during the day, which changed recently. Because a lot of people might be on sort of a 75 mg dose, a daily dose. Regardless of whether they've taken them or not, you give them the 300.
Yeah, that's a very true. That's a very fair point. If in doubt, ring through the chain of command and get hold of if you're uncertain of a medical professional to double check these things. But the absolute basic principle is right. If you're on a baby aspirin a day, which is what a reasonable number of people are on, then you still give the 300 milligram tablet. Right, it's gone 9, and I've been whittling on for coming up to 2 hours now, and I am keen to make sure that you guys are able to absorb information rather than just being bombarded by lots and lots of facts. So I guess from this point we may as well round up. We've still got quite a lot of theory stuff to get through, which I will send out another date for. This will go up onto the YouTube page, which you can watch back, or if any of your colleagues want to watch it, you're more welcome to. At this point, does anybody have anything they want to discuss? Any topic over what we've discussed tonight? Anything you want to clarify? Any questions you want to ask?
Just one, Patrick. Did the GTN spray bottle change in the last sort of 6 to 12 months?
Yes, it's a little white bottle in our kit.
It used to be red, didn't it?
Yeah, it's just who makes it.
Yeah, that's fine.
There used to be clear red bottles, and now they're little white steel cans.
Okay.
Anything else at all? No? Fine. All right then. Well, I hope you're still with me and you're not all disappeared. But in which case, I will leave you all to it. Thank you for joining. I'll send out a link, like I said, for probably something next week where we'll try and cover some more topics. And hopefully we're not too far away from wrapping a lot of this theory stuff up. And then after that, it's all about getting your primary survey and bits and bobs sorted. So if you've got no further questions, I will stop the recording.